If you've been seeing headlines or warning lists asking, "Is Nipah the next pandemic?" you're not alone. Nipah virus has a way of resurfacing in public conversations, often with dramatic language, because it sits in a very uncomfortable category. Rare, but potentially severe, and capable of person-to-person spread. I'm going to walk you through Nipah like a clinician would, clear, calm, and evidence-based. No doom, no hype, just the logic behind the warnings and what actually matters if you're trying to understand real-world risk. Before we start, this is general educational information, not personal medical advice. The hook most people miss: deadly doesn't automatically mean pandemic. Here's the counterintuitive truth. The viruses that frighten us the most are not always the ones that become pandemics. Pandemics are not awarded to the most lethal pathogen. They're driven by the pathogen that can spread efficiently through normal human behavior. Talking, commuting, indoor gatherings, schools, travel. That's why COVID-19 changed the world. It had efficient transmission in everyday settings, including from people with mild or even no symptoms. Nipah is different. Nipah can be severe, sometimes very severe, but it does not typically spread with the same ease through casual community contact. That tension is the entire story: high severity potential, limited spread potential, and that's why it keeps showing up in warnings. What Nipah virus is, without the jargon, Nipah virus is a zoonotic virus, meaning it's a virus that can move from animals to humans. Its natural reservoir, the animal group that carries it in the wild, is fruit bats, particularly bats in the Pteropus genus. Think of fruit bats as the virus's home base. A lot of viruses live in animals and never bother humans. The problem begins when human activity creates opportunities for the virus to cross over. That crossing is called spillover. Spillover is not science fiction. It's what happens when humans, domestic animals, and wildlife overlap more, through farming, deforestation, expanding cities, or food practices that bring us into contact with animal secretions. Nipah was first recognized in the late 1990s during an outbreak linked to pigs in Malaysia, and since then, outbreaks in clusters have been reported particularly in parts of South Asia, including Bangladesh and India. How people get infected. The bridge, from bats to humans. There are a few routes that matter. Bat to human transmission. This can happen when food or drink becomes contaminated by bat saliva, urine, or partially eaten fruit. In some regions, raw date palm sap has been implicated historically as a pathway for spillover, because bats can access collection containers overnight. Animal to human transmission, the middle step. In the first recognized outbreak, pigs acted as an amplifying host. Infected bats, pigs, humans. Pigs are not required for Nipah transmission everywhere, but they demonstrate a key concept. An intermediate host can multiply and distribute the virus efficiently in a way that increases human exposure. Human-to-human transmission. This is the reason Nipah is on priority pathogen lists. Nipah can spread between people, particularly through close contact and exposure to bodily fluids or respiratory secretions, often in caregiving or healthcare settings. Now the important qualifier: can spread person to person does not automatically mean spreads easily. What illness looks like. Why clinicians respect Nipah. Nipah infection in humans can range from mild to severe. But the severe end is what earns it its reputation. Early symptoms can look nonspecific: fever, headache, muscle pain, sore throat, sometimes vomiting. Respiratory symptoms can occur as well. Then in some patients, the illness progresses to encephalitis, which is inflammation of the brain. That can present as drowsiness, confusion, seizures, and rapid deterioration. When you hear people describe Nipah as a brain-swelling virus, they're referring to that encephalitis risk. Another detail clinicians watch: the incubation period can vary, and because early symptoms can look like many routine viral illnesses, the diagnosis is not obvious on day one. That matters for infection control, especially in busy hospitals, because delayed recognition can enable exposure events. The mortality question. Why you keep hearing 40 to 75%? You'll often see a case fatality range quoted for Nipah in the ballpark of 40 to 75%. Varying by outbreak and by healthcare capacity. That estimate appears in major public health references, including the World Health Organization and the US CDC. 2 points I want you to hold simultaneously. Yes, Nipah can be associated with high mortality in certain settings. And fatality rates are not fixed properties of a virus alone. They reflect timing of diagnosis, supportive care capability, outbreak detection, and who is being counted and tested. So the number is not meaningless, but it is also not a guarantee of what would happen in every place, every time. So why hasn't Nipah become the next COVID? This is where people's intuition often breaks. A virus becomes a pandemic when it can transmit efficiently from person to person, do so in routine environments, households, workplaces, public indoor spaces, and often do it before people realize they're infected. COVID-19 hit those conditions. Nipah, historically, usually has not. Nipah tends to require closer contact for transmission, often caregiving, household exposure, or healthcare exposure without strict protections. That creates clusters rather than explosive, self-sustaining waves, because transmission is more conditional. If you interrupt close contact chains early, identify cases, isolate, protect caregivers, you can often stop it. Here's an analogy I use with patients and students. A highly contagious respiratory virus is like glitter. You touch one surface and it's everywhere, including places you didn't know you visited. Nipah is more like paint. It's serious if it gets on you, but it doesn't automatically aerosolize through a crowd the way glitter spreads. That's not minimizing it, that's explaining the mechanics. Why Nipah keeps appearing in warnings anyway. Now to the real question in your title, why does it keep showing up in warnings? There are 4 reasons. 1. Severity plus limited margin for error. When a pathogen has the capacity for severe disease and high mortality, the tolerance for uncontrolled spread is low. Even a small outbreak is a major event. 2. Human-to-human transmission exists. Many deadly zoonoses never really transmit between humans. Nipah can, which moves it into a different risk category. 3. The pandemic potential scenario is plausible. Public health is not just about what is happening today. It's about what could happen if the conditions change: viral evolution, ecological shifts, more frequent spillover, travel-linked introductions, or outbreaks occurring in settings where containment is harder. To be very clear, that is a scenario, not a prediction. But scenario planning is responsible medicine. Before, tools are improving, but there is still no widely licensed vaccine or specific cure. Supportive care is the mainstay. There is not a universally approved specific antiviral cure for Nipah virus disease. The encouraging update is that vaccine development has progressed. There are Nipah vaccine candidates in clinical testing, including advanced trials reported by major research institutions and international initiatives funding trials in outbreak-prone regions. So when warning lists mention no vaccine, what they usually mean is no widely available licensed vaccine for general public use yet. Not no research exists. What the recent headlines are actually reflecting terror. When Nipah hits the news, it's often because of a cluster that triggers surveillance, especially in healthcare settings. For example, WHO has issued disease outbreak news updates for Nipah activity in India, Kerala, describing confirmed cases, deaths, and containment actions during 2025. And in late January 2026, multiple outlets reported fresh concern and heightened screening tied to suspected or confirmed cases in India's West Bengal region, alongside airport screening measures in parts of Asia. Whether every headline is perfectly written is another matter, but the pattern is consistent: small numbers, aggressive containment, high attention. That's appropriate. When a pathogen is high consequence, you don't wait for large numbers before you respond. What would have to change for Nipah to become a true global crisis? This is the part people tend to sensationalize, so I'll be careful and precise. For Nipah to behave more like a pandemic respiratory virus, you generally need some combination of more efficient human-to-human transmission, including transmission in ordinary community settings, more consistent respiratory spread with lower exposure thresholds, and/or more frequent spillover events that seed repeated outbreaks. Again, this is not me saying it will happen. This is describing what public health professionals monitor when they categorize pandemic potential. And I want you to remember, viruses don't want anything. They don't strategize. Evolution is not a villain with a plan. It's selection pressure plus opportunity. The reason we pay attention is because opportunity, in the form of human-animal contact and global movement, has increased over time. The good news: why containment can work. A major reason NIPAH is not a constant global crisis is that traditional outbreak control measures can be very effective when implemented early. Rapid identification of suspected cases, isolation of confirmed cases, meticulous infection prevention in healthcare settings, contact tracing and monitoring, community guidance to reduce exposure to likely spillover pathways. These are not glamorous interventions, but they work, especially for pathogens whose spread depends on close contact rather than casual airborne spread in crowds. So the message is not panic. It's take it seriously, respond early, and don't confuse severity with inevitability. What I want you to take away, especially if you live in the US, if you're watching from the United States, your personal day-to-day risk is generally low, and the correct emotional posture is not fear, it's informed awareness. Here's the clean framework. Severity answers, how bad can this be for an individual patient? NIPAH can be very bad, that matters. Spread answers, how likely is this to scale into a large outbreak? Historically, NIPAH's spread has been limited and cluster-based, which changes the global risk profile. When you hear next pandemic, your brain understandably goes to worst case. My advice, professionally, is to think in probabilities and mechanisms, not slogans. Finally, if you want a single sentence to remember, NIPAH is watched because it can be severe and it can spread between people. But pandemics are made by efficient spread, and NIPAH has not consistently shown that kind of transmission in the general population. That's why it keeps appearing in warnings. Not because catastrophe is guaranteed, but because preparedness is cheaper than surprise. If you want, tell me your channel vibe. Serious like a grand rounds talk, versus more TV doctor approachable. And I'll tighten the pacing and punch up the phrasing while keeping the expert tone.